When assessing range of motion in the cervical spine, there's a couple motions we're going to look at. The first one is going to be cervical flexion, so we're going to cue the patient to go chin to chest. Go ahead. Good, now back to neutral. Now cervical extension, we're going to cue our patient to look up at the ceiling. Go ahead. Good, now back to neutral. Now for left lateral flexion, we cue our patient to go left ear to left shoulder. Go ahead. Good, back to neutral. Then for right lateral flexion, we'll be cueing our patient to go right ear to right shoulder. Go ahead. Good, now back to neutral. And then for the rotation, we'd say left rotation, look over your left shoulder. Go as far as you can. Good, now back to neutral. And for right rotation, go ahead, look over your right shoulder as far as you can. Good, now back to neutral. Now for these range of motion, that was all active. You can assess them passively and resistively also. Now if you have pain in some of these motions, they could indicate some common injuries in the cervical spine. Some of these injuries could be a facet pathology or a disc pathology. So when I'm looking at a facet injury, if I'm looking at a possible left facet injury, we would look at extension, so go ahead, look up at the ceiling. Now left lateral flexion, and then rotation to the right. Good, now that will close that left facet, now you can return back to neutral. If I was looking at a right facet, it would be extension again, right lateral flexion, and then rotation to the left, and it will close that right facet. Back to neutral, good. Now if I was looking at a disc pathology, flexion, so if you're gonna bring chin to chest one more time for me, this would be a painful position for them because you can return to neutral. This will put pressure on the anterior side of the disc, pushing the nucleus propulsive in a posterior direction. For a person who has a disc pathology, you would expect extension in prolonged position to help with their pain, so go into extension. Good, so we would have them laying on their stomach watching TV, something like that. You can go back to neutral. This will put pressure on the posterior side of the disc and push the nucleus propulsive back anterior. That is a range of motion at the cervical spine. For task 2, we're assessing range of motion at the C8, T1 junction. Now to palpate, I want to have my patient sit up for me real quick. Now I'm going to have my patient flex your neck, so go chin to chest. This will help the C7 spinous process stick out. Now you can return back to supine for me. Now that I'm on the C7 spinous process, I can go down to T1 here and feel the spinous process. Now I want to move up and onto the transverse processes here with my fingers. Now I'm on the transverse processes of C7 vertebrae, and I can apply here. This would be a bilateral anterior to posterior glide. And I'll find the end range and then apply oscillations for about 30 seconds, 15 oscillations. Now if I wanted to do a unilateral glide, I would again find the C7 spinous process here, T1 spinous process is here. I would move my finger up to the transverse process of the C7 and again apply my anterior to posterior mobs on the end range at oscillations of about 15 oscillations for 30 seconds. So for the special test for the Lissette battery, the idea is there's 5 of them. If you have 3 or more positive tests, that indicates the SI is a likely source of the pain. And if you have 3 or more negative tests, there's a good chance that it is not an SI dysfunction. Now for the first one, it is supine SI distraction. So I'm going to go over, I'm going to palpate the ASIS on my patient, and I'm going to apply bilateral pressure. This is supine SI distraction. A positive test here would be pain or reproduction of symptoms in the SI joint. The next one is going to be sidelining, so I'm going to have you face that wall. So this is SI compression. Now I'm going to palpate the iliac crest and then apply a downward force here. This will be apply a compression force on the SI joint. Positive test here would be increased pain in the SI joint, reproduction of symptoms. Now the next test is going to be prone, so you're going to flip on your stomach. So go ahead, lay on your stomach for me. Now this one is the sacral apex pressure test. So we're going to find the apex of the sacrum here, and we're going to apply a straight down force here. Now positive for this test will be again pain in the SI joint or reproduction of symptoms. Now for this next test, I'm going to have you lay on your back for me. This is going to be the thigh thrust test. So this is the 4th test in the battery. We're going to bring one leg up like this, and I'm just going to apply an axial load down through the thigh just like this. And this axial load going straight down, if it produces pain in the SI joint or reproduction of symptoms, that would be a positive test. Now the last test here is going to be Galen's. So go ahead and bring both your knees to your chest for me. Good, now I'm going to slowly and passively extend this knee down and off the table. Now what this is doing is causing a rotational force on the pelvis in the SI joint itself. You can apply a little bit of overpressure but if they have pain, you want to back them off of it just so you don't put your patient in any uncomfortable or unneeded distress. So again, if there are 3 positive tests of that battery, it indicates that the SI could be a source that's dysfunction, and then if there's 3 or more negative tests, it is a good chance it is not the SI dysfunction that is causing the symptoms. So when you have a patient returning from a conservative treatment on a spondylolysis for the L4 vertebrae, what we're most concerned about here is a fibrous union being formed instead of a bony union. Now this will cause a increase in the range of motion, a decrease in stability. So what we want to look at here, the first thing I want to evaluate is the range of motion for that L4 vertebrae. Now to find the L4 vertebrae, I'm going to palpate the iliac crest, go right over here, find the spinous process to L4. I can check my work by going down on the L5 spinous process here. Now if I go back onto the L4 spinous process and apply glides in a 90-degree direction straight down, I can assess for range of motion in the lumbar spine and see if a possible fibrous union had been formed instead of a bony union. This could predispose us, our athlete, to more injuries in the future. Now I also want to look at some range of motion in the lumbar spine as a second criteria I want to look at, so I'm going to tell my patient to stand up for me. Now when I look at range of motion in the lumbar spine, the first thing I want to look at is just straight flexion. So I want you to go ahead and go down and touch your toes and make sure you roll your back. And I'm looking to see if there's an increased range of motion, any pain. You can return to neutral again. So any increase of range of motion that is not to be suspected would be a good case to send them back to the specialist. Now the next motion is going to be lateral flexion to the left. Go ahead. Now I'm looking to see if they are either missing any range of motion or there's too much range of motion in any specific direction. You can go back to neutral. Now right lateral flexion, go ahead. Good, again, you can return back to neutral. And the last one would be hand on your hips, like this, and go into lumbar extension, just like that. Now we're looking to see, go ahead and return to neutral, if they have any increased mobility or pain that could predispose them to injuries down the road. Now, when doing a concussion screening, the VOMS, or vestibular ocular motor reflex screening, is really important to looking at if you want to distinguish between an ocular or a vestibular subtype of concussion. So the first test we're going to look at is smooth pursuit. Now I'm going to hold this pencil about 3 feet away from the individual. I'm going to tell her to keep her eyes on the tip of the pencil. Now, keeping your eye on the tip, I'm going to move horizontally first. Good. Now vertically. Good. Keeping your head nice and stable and just moving with your eyes. Good. So that's smooth pursuit. Now the next one is saccades. So what I'm going to do is I'm going to put 2 objects about 3 feet away from each other and 3 feet away from her face. I'm going to tell her to look back and forth from the tips of my fingers as fast as she can. Go ahead. Good. You can relax. Now do that for about 10 seconds and then wait 10 seconds and see if they have any reproductive symptoms. And that would be the same thing for the smooth pursuit, if they have any problem tracking or if they have reproductive symptoms. Now the last one for the ocular cluster is the convergence. So I would tell my patient to focus on a very minute object on this pencil, like this number 2 right here. Now I'm going to bring this object closer to the patient's face, and then I want her to tell me when her vision starts to get blurry or she starts to see double. So go ahead, I'm going to slowly move it in, and she's going to tell me when she starts to see double. Good. Now I can measure that distance, and then depending on the age, if it's anywhere between 6 to 8 centimeters, that's average for anybody ages 10 to about 18, and then 18 to 27, anywhere from 8 to 10 centimeters is about average. Now those first 3 are for ocular. Now these last 2 are more for vestibular. So for the VMO, visual motor sensitivity screening, we're going to have our patient hold their thumb out straight in front of them. Now at about 50 beats per minute, we want to have them rotate their torso about 90 degrees and keep their eyes on their thumb. So go ahead, about 50 beats per minute, a little bit faster, all the way 90 degrees. Good. Now we're looking for reproduction of symptoms, any type of headache, nausea, anything like that. Good, you can relax. Now the last one is the VOR test. So for this one, you're gonna, same thing, hold something about 3 feet in front of your patient. And for this one, you want to keep eyes on the target, but go up and down at 180 beats per minute. So it's pretty fast, 180 beats per minute. And also, again, you can do that vertically, yes and no, and then horizontally like this at about 180 beats per minute. Then you'd want to, good, you can relax. You want to wait about 10 seconds after and see if they have any reproductive symptoms. So for somebody recovering from a rib stress injury, you want to look at diaphragmatic breathing. Now, the whole idea of diaphragmatic breathing is the diaphragm is the top of a can, and the pressure in this can can really help when transmitting force from the lower extremity to the upper extremity in a lot of our sports. And when you're recovering from a rib stress injury and you have poor breathing mechanics, you don't want your chest to move necessarily as much. So the whole idea of diaphragm breathing is really kind of engaging your abdominal muscles to help kind of take the load off of your rib cage. So when I am cueing somebody to do diaphragmatic breathing, I want to talk to them about how an exhale should be a passive process, and then on the inhale, we want to bring their stomach up to the ceiling. So on a nice relaxed exhale, and you can go ahead and have an inhale and kind of feel like you are keeping your rib cage relatively stable and kind of breathing through your stomach. So I can provide tactile feedback by cueing her. So go ahead, take a deep inhale. Good. Now you can see she has great diaphragmatic breathing control. She's breathing through her stomach, and then you can exhale. Great. Now, the whole idea behind this is you want to, again, take the load off of that rib stress injury and kind of cue them to kind of visualize breathing through your stomach by your belly button going towards the ceiling if you're laying on your back like this. So one more time, take a deep inhale for me. Good, you can see her diaphragm is contracting, and then good, relax, and that's a good passive process.